welcome to the intro of the intro to the Sports Medicine Project. Kelly and I yarned for way too long. It ended up being about 34 minutes, but enjoy part 2 with Dr. Rich Willy. Kelly, anything to say?
Yes, just skip through to, what do we say?
34 minutes
if you don't want to listen to us talk.
Yes.
And just to get to all the good stuff with Dr. Rich Willy. Part 2.
Yeah. Enjoy.
Welcome back to another episode of the Sports Medicine Project. I'm here with my co-host, sub-90 half marathon runner, Blake Withers.
Nice to be here, Kelly. Thanks for that introduction. Yeah, it was I don't want to get into tell the story, but that's probably my biggest running achievement. Other than it's on par with a sub 25k.
Sub 20. Whenever you say sub 25k,
You think it's sub 25k?
5. Yeah.
I don't think people would ever use that metric though.
Me
would
either.
they? You know, it's all relative because we look at, and I think and I'm going to tell this story when we talk about a couple of things that happened this week. It's all relative when someone's talking about their meaningful activity. So if someone's sub 15, if that's a challenging thing for them, it's the same as someone running sub 30. Like your mum, for example, what's her? She's
35-minute park runner.
Yeah, and for her to get under her PB, it's the exact same as for me going.
Same RPE.
Yeah, same RPE and same nostalgia, maybe same congratulatory emotion. I don't know. It is really nice to see people hit their goals when they do train for it.
Yeah, that's the best thing about volunteering for parkrun, particularly when you're on the finish line, because people come across and they're like, "Oh yeah, I got my PB," and you're just like, "Yeah, you got it." It's exciting.
Yeah, you're right. I thought you were going to say that's the funnest thing about working as a health practitioner, helping people get back to their goals. Kind of like a PB every time.
So cliche to say that.
Yeah, but it really does, and we've got a couple of topics to talk about of this exact nature. And I did a post about it this week, not last Friday, the Friday before, a lady that I saw with a unilateral, somewhat adult-acquired flat foot, looked like more of a stage 1, stage 2 tibialis posterior dysfunction, so a progressing deformity. And yeah, I saw her 6 months ago with this acute flare-up. Funnily enough, and this is another topic I'm going to talk about, she was seeing this physio that I'd never heard of, this practice out at Warners Bay, which is, I think it's like 20 minutes from where I work now. And he tried some rehab and some taping, and she got a really good response from the tape. He's like, "Great, you need to go and see a podiatrist." And no, didn't specify anyone. He just said, find a podiatrist, and she happened to book with us online. And yeah, posted that on the Instagram. She's now back hopping and jumping and doing single leg calf raises and doing a step class and walking with her family. And it was just like, that is so rewarding. And it is cliche, but it really is. It really is. And that, I don't know if that's the driver for me to I want more of that. I want that to happen all the time because it feels really good. So that's kind of the fire to then sit down and study and look at papers and mentor and ask questions. I don't know.
I feel like sometimes it's the little wins though, just like when people grasp what you're talking about.
Yeah.
When they get it and they reflect on it and they're like, wait, so I probably should be doing more of this stuff rather than this stuff. And you're like, yes, you get it. And it's like, those are the things I'm like,
yeah,
I must have explained that well.
Yeah, that is true. It does make you feel good. That's why we do it. Seeing someone, I would say if someone said, elevator pitch, you got 20 seconds in the elevator, why are you a practitioner? 1, to help people get back to their meaningful goals. 2, increase someone's understanding and health literacy about their own body. And thirdly, I like to see runners, so hopefully see them get their PBs. And I was a part of the journey, if that makes sense. Actually, I've got a good announcement for everyone listening to this. Over the next however long, we are going to be co-coaching 2 people running coaching, and the agreement is we're going to share all the metrics and the journey, why we did what we did, all the coaching strategies. And one person's doing a 50k ultra and one person's going for sub 3 hour at the London Marathon. I told you that, hey. I've said it in passing, but you didn't believe me.
You have said it to me as if you're coaching them.
Well,
you just need my help.
Well, one of them is, and I know he listens to this podcast, 2 of them, I think. One is a previous patient, which I'm excited for. So he had a previous second met Stressy, and we managed it over here, and then he is over in now he's over in London, and the other one is a physio, but he's overseas in I don't know what town. But yeah, really exciting. I'm keen for that, and I'm excited to get some feedback from yourself and from everyone. Yeah, it'll be cool. Anyway, let's get stuck into some topics. You want to talk about your week? Mondays, 440s. They're crazy, those guys.
My highs and lows. My other high of the week, I had a lot of, I don't know if this is the right word, but inter-family referrals. So family members referring family members to see me this week. And it just made me feel really good. It made me feel very trusted and as if I had helped them and they wanted me to be able to help their family member, who's obviously someone that they love and care about a lot. So that was really nice to think back and reflect on. There was like 6 or 7 into family, I'm going to go with that, into family referrals. Yeah. And that made me feel pretty good.
Yeah. I wonder, when we're just talking about why you're a practitioner and why you help people, there is definitely a feeling that you get, and I'm very happy to admit this. I don't see it get talked about very much, but when you get it right, it makes you feel like you're good at something. It's like if you run a really quick 5K, you're like, oh, maybe I'm pretty good at running. When you're continuing to get it right, and that's a good example where somebody refers someone else to you, it makes you feel very trusted and knowledgeable. It's like, wow, maybe I am doing a good job, or I do know what I'm talking about. And maybe you think, the last 4 years I spent studying, and every night I come home and I sit at the computer and I look at research and I get feedback from as many people as possible. It's all worth it because I'm able to help these people because they wouldn't send someone to me otherwise. Yeah, good on you. That's good. That's really, really good.
And one of those ones was someone that you had sent to me you were seeing her for thickened nails or something. And then
yeah. Can I tell you?
Yeah, go.
So saw this person. Was she a runner? She wanted to get back into running. Netballer. Yeah, so young, healthy. She gets psoriatic nails, and for anyone that isn't a podiatrist, some people might know what it is. You can have like psoriatic arthritis, but there's a condition called psoriatic nails, and there's probably a more medical term. But it's basically you have thickened nails, and they can rub and irritate. It's really common. Sorry, it's not so common, and it's really hard to manage unless you have this little special drill called a burr. So, funnily enough, I was seeing this person for that, and as you do, discussing and talking, and I guess what I wanted people to get from this kind of story is to always delve deeper into, I guess, someone else's, not their medical history, but other pathologies and things they can have going on. So we were, in this case, talking about her knee, and was telling me the story about the knee, saying that she'd had an MRI, and there was a lot of arthritic change. It wasn't that painful, but it was painful. She wanted to get back into running, and another health professional told her that's probably not the case, and she had been receiving quite a lot of passive therapy. And I would never ever say, stop doing that, stop seeing this person, go and see someone else. I just suggested that, generally with good strength and good rehab, a good low progression, most people can get back to doing what they love. And then over time, she eventually asked if there was someone that I would recommended someone because you wanted to get back into running, which is yourself, and then it went from there. And this person is, which you'll finish yourself, she's back doing everything she wants to do.
Yeah, so she did a lot of strength work with me, and she's doing really well. And from that, she had sent me, her daughter came in to see me, and then this week her son came in to see me, and that was a really good referral, the one that I saw this week. I had to actually get him in to see an ortho pretty soon from what we picked up. So yeah, it just those connections that you build from something really simple like psoriatic nails.
Even like just asking more questions, and we always say, tell me about the foot and the ankle pain. How are your knee? How are your hips? And someone's like, oh, my knee's really sore. We'll obviously focus on the foot and the ankle, a little bit of the knee, but we'll come back to them and go, hey, how much is that bothering you? Because I can definitely treat and manage the foot and the ankle in combination with someone else who can manage the knee because they're a lot better. And I did want to add, and this is one of the topics I wanted to talk about, referring or referrals to other health practitioners. One thing that I've been trying to do, and definitely getting better at it, is referring outwards, even with things I could probably manage. So I've had a couple of people where I haven't actually managed their run programming. Sometimes I do in the first stages. I'll send them off to a run coach or to other physios, even a couple of chiros I've sent to the sports doctors. Yeah, been really trying to get some referrals generated outbound.
You know who I really want to get on the podcast? Mm-hmm. Some of the sports doctors. We talk about them all the time. They are so knowledgeable.
Yeah.
Surely we can pull some strings and...
Yeah, well, Andre's going to come on, Dr. Boyko. He just had a baby, and I could definitely ask Neil and Jin.
Yeah, I would love to pick their brains on the podcast, and we always talk about referring to sports doctors on this podcast.
Of that. Yeah, I don't know if people. I mean, how would you describe? This is probably a really good topic, and we can scratch one of the other ones I was going to talk about and talk about this. Sports physicians, sports doctors, and talking with them as well. And like we don't work within that. We just happen to be in the same building. They are not probably utilised as much as what they could be. I didn't learn about them at university. I don't know about other health practitioners. Did you learn about them as a physio?
No.
How would you describe their management? I would say
I don't know. That's why I think that they need to come on and talk about it.
Yeah. If I'm seeing someone and they're not improving after like a couple of sessions, even 3 to 4 sessions, and I don't think and this is not always the best judge, but if I don't think they're a pure orthopedic referral, I am sending them to them for the management. And they are so knowledgeable, and they've just got this wide array of knowledge in all these different areas, especially musculoskeletal health.
And the other thing that I think they're really helpful for is requesting the right imaging. You know, sometimes you just don't know, and
you don't know what you don't know.
You don't know, and also, if you're sending for an image, then you need to be able to manage the outcome of it or know how to, deal with what's being picked up. And sometimes with those more complex ones, it needs to kind of be escalated to them anyway. So I think that's where they're really helpful as well.
Yeah, and like even the differentials between X-ray and MRI, like sometimes X-ray is actually so much better. But you kind of gravitate like, I don't really know what's going on. I better get an MRI, whereas an X-ray would have been better. Yeah, they are an incredible discipline that I think. And if anyone is in Newcastle, like it's hard to describe when you would send them on and reach out if you and we've had a couple of people ask some questions about patients. Yeah, just a matter of, would you say a couple of sessions, 3 to 4 sessions, something chronic, something you don't know what's going on, it's not responding to what you think it is. That's probably the case for them. And I guess, I don't know if it's worst case scenario, but the common scenario is they just confirm what they're thinking and go, great, it is this, and then they usually send them back.
And an analogy that Dave often uses is, what does he say? He says, like, if it looks like a duck but it sounds like a cow or something like that, like if it's just not behaving the way that you would expect it to, and you just have that yucky feeling in your tummy, then sending them off straight away just to rule out anything sinister or nasty.
Yeah, I wanted to ask you a question, and we're going to cut this at about 20 minutes. I'm going to skip my highs and lows. I wanted to ask you a running progression, return to running rehab. I posted this on the Instagram story. What I did this week with a lovely lady who had been dealing with a flexor hallucis longus. So initially couldn't run, got her back to now being able to tolerate 3 by 6 minutes with pretty minimal pain and able to do that 3 to 4 times. I was thinking, should I just move that straight to 20 minutes of a full run, or do I keep progressing that 3 by 6 minutes, with 2 minutes in between as a recovery? Do I keep progressing it to like 3 by 12 or 3 by 10 and then go to 20 minutes? Or when do I do that? Because my thought and what we had gone with is we're going to go 3 by 6, 2 minute recovery. You've got to do 3 successful runs, which she had done, going up to 3 by 11. And you've got to progress as 3 times 7 minutes, 3 times, she runs nearly every day, 3 by 8, then 3 by 9, and 3 by 10, and 3 by 11 to 3 successful, and then to 20 minutes straight, and then progress by 5 minutes. What do you think?
You were speaking so fast just then.
I know, because I want to get your opinion on it, because it was just come to me on the spot. I was like, this is it. This is the new return to running protocol.
Well,
this is going to be in BJSM tomorrow.
There is a right or wrong way to do any return to running. I think you could do either.
That's not the answer. We want to generate the fire.
Well, I guess it depends on her irritability and how maybe like nervous she is to progress her running, or how confident she is to give it a crack, or what the injury is as well. Like if it's a bone stress injury, you'd be maybe erring on the side of caution. If it's a tendon, then if it flares up, it doesn't matter. I think they're the things that I'd be thinking about.
Do you usually say 3 successful runs, or you just progress them each time? And
I progress each run.
Yeah. Because what do you do? It's 2 minutes, 1 minute, 2 minutes, 1 minute, is it? You do something different?
It depends. I kind of just make it up, depending on the person.
Wild.
Lately, though, for more like tendony type of injuries, I do more of a 4-minute walk, 1 minute run, then 3-minute walk, 2-minute run, then 2-minute walk, 3-minute run.
Oh, yeah.
4-minute walk, 1 minute run.
That's the most
4-minute run, 1 minute.
Yeah.
If it's more of a bone stress injury, then I'll usually do like minute on, minute off times 5. Then the next run I'll do minute on, minute off times 8. Then the next run I'll do minute on, minute off times 10. And kind of get that to like 15. And then I do like 2 minutes on, 1 minute off times whatever.
Go from there.
And then make sure the volume of each of those is kind of building. And then I calculate the weekly volume at the end and make sure that the weekly volume is increasing, but not too crazily. And then at week 4, I'll usually make it a bit of a deload and then go from there.
Nice. Cool.
That's what I tend to do.
Yeah.
I just have a template that I just use, and then like depending on the person, I'll just modify it a bit.
Yeah, cool. Yeah, I think we did send out a template to some of the listeners, I think.
I just think there's so many ways you can do it though.
Yeah. If you're listening to this right now and you want a template, what can we make them? What's something that we need? 5-star review. 5-star review on Spotify and Apple Podcasts. Send it through and we'll send you a template and $50. That's pretty fair. That's not conflict of interest. Next 2 topics I want to talk about that I've been learning over the last couple of weeks as I'm writing this pain narrative review. Talking about pain and genetics and also catastrophizing. Some people, so we know genetics play a role in everything.
Wait, I've got a bone to pick with you.
Yeah, what is it?
You write catastrophizing on the board for patients. I don't think that you can do that.
When? In the Instagram stories?
No, when you're seeing patients.
When?
You write catastrophizing in their cup. I would be so pissed if I was coming in to see someone and they wrote catastrophizing in my cup. I'd be like, excuse me?
No.
It's like stuck onto your wall.
Oh, yeah, in that cup. Yeah. I know the one you're talking about. Yeah, I don't usually, I point to that every now and then. I still don't think there's anything wrong with it. If you're able, I'm really confident, and I may be getting it wrong, that might be a blind spot. I'm really confident in explaining what catastrophizing is. So when we're, like, if they're sitting there and go, I know, like, we're talking about it, we're asking where it's sore, we're trying to make it sore, we've just talked about it for the last 45 minutes, even us just thinking about it can play into it being sore right now.
Is that catastrophizing, though?
Well, we're thinking about it and talking about it.
I don't think that's catastrophizing.
What do you think catastrophizing is? I actually wrote the definition down in the review.
People that are like, my back's so sore that I'm never going to be able to work again and I'm never going to be able to play with my grandkids ever. And I think that's what catastrophizing is. I think people can talk about their painful problem without it being classified as catastrophizing.
Well, if we talk about it in the sense of pathology and injury, is it not feeding into the injury? Like, yeah, my heel's sore, I can't do this, I can't do that. That's ruminating over the injury, which is catastrophizing.
I don't think so.
I have to have a look at the definition. Yeah, maybe that
Let
is.
us know,
Maybe I could take it down. What would you rather instead? So how do you describe catastrophizing?
Let me just ask you a question.
Yeah.
If you had a sore knee and you walked into a clinic and the physio or podiatrist or whoever told you that you were catastrophizing.
But no one does that. You know, I'll stop you right there because I don't say to someone, listen, this is why it's sore, you're catastrophizing. Because that's not the way that we would ever explain it. We don't say...
How do you explain it then? When it says, like, do you ever point to catastrophizing on that cup?
No, I really hardly ever use the cup because it's different for everyone. And depending on I will really individualize it to the person sitting there. So I'll, in most cases,
I swear I've seen you write it though.
Yeah.
Somewhere.
No, I would never write. It's too big of a word and I can't spell it. I'll like draw the cup and use their individual factors and a couple of other things like stress and sleep and previous injury.
Okay.
I'll kind of merge catastrophizing and kinesiophobia into one because they're two factors, and that's what I've been reading as well. They're probably the two most important factors. So the positive feedback loop of kinesiophobia, which is fear of movement, for an example of my heel's sore, I don't want to do this movement. You then avoid the movement, then the tissue adapts to the environment that it's in, goes great. I don't need to be adaptable for running because I'm not being exposed to it because I've got a fear of it. Then that feeds into it becomes weak and sensitive and whatever. And then when you go back to do the movement, it's even sorer. So it feeds into that loop. So I'll definitely explain that one. I've been using that a lot. The tissue adapts to the environment that it's in. So always trying to keep some level of load is great because we don't want to lose that adaptability and then increase the sensitivity.
Yeah, I like that. That's great.
And the other one for catastrophizing, I probably don't describe the definition, but I will always anticipate. I will say to them, it will be very likely between now and when I see you next, because that will happen. We know that the body is complex and we can't always predict how it's going to respond. I'll say it's very likely you will have a couple, if not several, flare-ups. That's very, very common. And what we typically see is when that does happen, you can get feelings of it's gone backwards, it's not improving, I'm not going to get back, and you can really think about it. So there's two things from that. One, that can mean that you stop doing the things that are good for you, which is what we don't want. And then the other side of that feeds into the pain because of the pathways and things. And I won't get too much into the psychology of it, but I'll explain it in that sense.
Yeah.
Which seems non-threatening.
Which is reassurance. So if I've identified that someone's catastrophizing, I will make more of an effort to reassure them that bending is safe and, pain doesn't equal damage and things like that.
Yeah.
Is more what I tend to do.
Yeah.
Which is exactly what you just said that you do.
Yeah.
Which I agree with.
Yeah. Yeah. From what I'm reading, the research is pretty clear now. Like, it's evident that these psychological factors have an association, not a correlation, with persistent pain. Like, whenever you get two groups, and even if you look at them cross-sectionally, you have one group with this pathology and this group without it, these people on the other side with the pathology show more stress, reduced quality of life, signs of anxiety and depression, catastrophizing, and then also when you look at their recovery time, those people that tend to take longer to recover show those psychological factors as well.
Is that surprising to you?
Not surprising, but I don't know if, and I'm not this magical wizard that's incredible at managing pain, but I don't see anyone ever talk about it. I don't know, do you see anyone? Like, I hear people talk about mechanics and gait and this pathology and do this rehab, but I don't hear anyone say, this exercise is great for an Achilles tendinopathy. However, these other psychosocial factors can influence, one, how long it takes them to get better, two, what percentage of capacity they actually end up getting to, and also the pain that they have during. Like, I think that's so important to address. Like, we know that it's happening.
Can you address it though? Like, can you address someone's
that's the thing.
Anxiety or depression or psychological state? Like, I don't know. Like, I think we can reassure them and provide people with good education and give them
well, that's what I mean by
feeling
doing
of
that. Yeah, it's like that's what I mean by managing that. But then also on the flip side of that, what I'm reading is learning that when people manage these factors, there's two sides of the coin. One side is people say that they don't feel that they've, one, had adequate training as one. Two, they feel as though it causes them psychological distress when they provide empathy to patients. And three, they don't actually understand how to objectively quantify. And this is just based off interviews that they've done in the physiotherapy profession, not in the podiatry profession. So there's lots of factors that influence how clinicians manage it. And there's also factors that impact on clinicians. There was one study that showed maybe it was empathy and something else, but the more empathetic you are, the more psychological stress they felt like it caused them. That's pretty it's pretty full on.
Wait, the more empathy you provide them.
Yeah, the more psychological distress it causes on the clinician. So if you're a patient, the more empathetic I am to you, managing and understanding all these other psychosocial stresses, the more it impacts on myself.
Right.
And I've seen...
Which is, okay.
Like we've sat in with chronic pain physios and it's draining. It's very, very draining. Hats off to anyone that deals with persistent pain. It is draining, and I'm definitely, and I want to come across like that. And even the review as well, it's just identifying this gap. It's not to say that we're doing it the best and we're incredible at it, and if you're not doing it, that's the wrong thing. It's not that at all. We all need to try and come up with these ways to all get better, to help our patients. And I
think to reflect on yourself as well, and recognize when you are feeling drained from dealing with people, because talking to people and working with people all day, seeing sometimes up to 15, I don't know, maybe sometimes 20 patients for some people, that's hard, and it can be really challenging, particularly if, I think we were talking about last week, those weeks where you're not feeling as energetic as you might normally be, but you still have to pull some energy for your patients because they're the most important people in the room. That can be really taxing on yourselves. So having times where you're reflecting on how you're feeling is so important to minimizing burnout, I think.
Yeah, definitely. And burnout's so common. What's the dropout rate? It's 3 or 5 years. Yeah, I wonder if, and I've been talking with a lovely chap down in Adelaide, weapon runner. Won't say his name because I don't know if he wants me to say his name. But we were talking about, he's just started as a new graduate, and we're sending long voice messages to each other. It was good. It was good to hear his perspective. Sounds a little bit romantic, doesn't it? But anyway, he was saying the clinic that he is in, he enjoys the clinic, but it's very heavily GT based, which is general treatment, which in podiatry is just code for nail care and skin care. And he's quite passionate about MSK, musculoskeletal and biomechanical podiatry, and trying to get involved in that environment because it makes you feel really good. And it made me reflect of where I started as a new graduate to where I am now, and the fulfillment and enjoyment and how excited I am to go to work most days, not all the time, which is normal. Yeah, and I know it's a lot easier said than done. Getting in that environment can really just be such a stimulator and stimulation for your life, where you're like, fuck yes, I cannot wait to get to work, talk with these people, see these patients, and get good, to then chase the feeling of what we said at the start of the podcast, where you're helping people and you're getting better.
Yeah, we've really gone 360 on this intro.
Oh, yeah, that was good. What a turn and burn at the end. Yeah. My heart rate was getting up. I was getting excited about that.
Zone 3?
Yeah, Zone 3 train. I'll do Zone 4 and 5.
But the other thing that I was just going to say with that is...
Yeah, frickin' say it. Get it out there.
I think it is good as a new graduate to maybe dabble in areas that aren't your passion area, because it just makes you realize how much your passion area is your passion area. Like we were at our job that Blake was just talking about, we would see a runner maybe like once every 3 months, and we would come home and we would be like, I saw a runner today. It was the best day ever.
I reckon we would have mismanaged those runners, because if they come in, I'm like, sweet, I just spent 6 months learning everything there is.
I unloaded
here is
on
an
them.
hour. They like walk out and be like, all these bands and exercises, running progression and shoes, and they're like, what did he actually say that was going on with me? It's good to have. And then I was talking with him as well about, I wouldn't feel, and I was talking about this with Justin as well, we wouldn't feel this if we didn't have that. But then also on the flip side of this, it's like an 8-sided coin that we're flipping around, where I think to myself, if I had started in the environment where I am now, how much better of a clinician would I have been? Just hypothetical question. I don't know if... you don't think so?
I think... So I've had 3 jobs now, and I think I have gotten better across each of them because... I don't know. I think because I've reflected on that previous job and what I'm like, I didn't do a very good job of that. I'm going to do better this time. And then I look back and I'm like, okay, those are the things I didn't do very well. I want to be a better employee at this job with these various things. But maybe, I don't know. I think there's, if you get your dream job straight off the bat, that's amazing. But I don't think it happens very often, and it's okay if it doesn't happen because you can still get there.
Yeah, and you hear people talk about that, having multiple jobs definitely does help your perspective. It's interesting. Yeah. Well, shall we end it there? About 16 minutes in, we said we go 20, and I'm looking 30:48 on the clock. That's all right.
That's a very fast 10K that we've just talked through.
Yeah, I'll be there soon if I keep up this zone 2 training. So the thing I was going to say, because I'm running quicker for the same heart rate, I was thinking to myself, if I just keep this up over time, I'll be able to get slowly down. I'll be running like 3-minute Ks zone 2. Because it's the way it trends. I can only imagine it's like that steep curve where you get really good and then you get the diminishing returns. That's all right.
It'd be nice to be able to run under, around 4:45 at 130 beats per minute.
Well, we're hoping to go to, and if you listen to this and you're going to go to the Brisbane conference in the A-Pod A, I really want all the pods to come together, all the podiatrists. And I think you said you wanted to come to this conference. Yeah, when is this? I don't know. I think maybe it's in June.
I want everyone to go for a run. Because I want to watch Ian Griffiths present.
Yeah. I just want all of us to get up early and all go for a run like Mike Winishki and Matt Clark. And I haven't met them, but I haven't met Tom DeCanto and
Man, I'd need
Griffiths.
to taper for this run and bring my Vaporflies.
They'd be up there doing their 410s. I'd be tights, gels, headphones in, tapered. Yeah, I reckon the chat would just be so much fun. Talking about shoes and carbon plates and tape and low-dye tape.
Except I'd be zone 5ing and there wouldn't be much conversation coming from me.
It'd be fun, but it'd be really fun. I could even picture I'd wear, as a bit of a joke, I don't know, got this far to listen, I'd probably wear one Alpha Fly and one Vaporfly and see if they think it's funny. Because only podiatrists would find that funny. I don't know if they'll even find that funny. They'll be like, who is this kook?
Yeah, I think so.
They'll look at the watch going, we're just going to take it down a little bit, and I'll go, nah, I'm out of there. But that would be cool. I'm looking forward to that, if that ever happens one day. And then on top of that, at the end of it, so we just get back, endorphins are running, we all sit around and we do this awesome round table discussion. Just because they're the people that I really think, and everybody is doing that as well, but I really value their contribution to the podiatry degree and the podiatry profession, and it also just the musculoskeletal profession, physio, chiro, osteo. They present an A-Pod A, they're really good. So I'd love to be this fireball question where you're just hey, how do you think orthotics work? How do you think shoes work? How do you manage a capsulitis? And they're just banging all these awesome things, and then we send that to these younger clinicians like myself when we all get better. Would be cool. But anyway, should we end it there? Sounds good. Any parting words to say to the local clinicians?
We had great feedback from part 1 of our podcast with Rich Willy, so enjoy part 2. All the missing bits and pieces that we wrote down in the post, but you didn't actually get to listen to last time. So here's part 2. I'm excited to re-listen to it. So enjoy.
Yeah, enjoy, legends. Have a good week.
They may use a tuning fork where they basically hit a tuning fork on a hard surface, and then they put the tuning fork on the bone to see if it reproduces the pain. The other way that you'll see some people do this will be to use a diagnostic, or not diagnostic, but a therapeutic ultrasound unit and run it over the bone and see if that elicits pain. And with the idea being that if it elicits pain, that's going to be an indication that that's going to be a bone stress injury. That's been done in the United States for a really long time. However, the accuracy of that is terrible. You're more accurate if you flip a coin. And so what we see a lot of times happening is that people have all the signs and symptoms of a tibial bone stress injury. Someone will do this tuning fork test on them. It won't elicit pain, and they'll be like, oh, you don't have a bone stress injury, you can keep running. And then this ends up being this injury that just keeps on dragging it out and itself out, and maybe perhaps even becoming more severe, and then takes a longer time for that athlete to recover. So anyway, so those are MRI is the gold standard for diagnosing these injuries, as you know. And so if that's what you're going to do, that's great. Radiograph is often done, but that, as I mentioned earlier, that's going to miss a lot of the early stage bone stress injuries.
I wanted to, sorry to butt in there and ask around the, like when they are hopping, if they have some discomfort, and I'm sure the severity of pain would determine, probably, or be likely to determine how severe the injury is. If they do have a little bit of discomfort and you can reproduce some diffuse pain, it's kind of on the verge, you imagine it is kind of a stress reaction or some bony edema. When do you say, no running for 6 weeks, or what's your kind of black and white there based off your clinical assessment, which is always hard, I know.
Yeah, I mean, if it's medial tibial stress syndrome, that's something you can continue running with, and so if that footprint of that bony palpation that's very tender is 5 centimeters, there's a really nice study out of Israel that was published 2 years ago with their military, and they found that if you have tenderness that exceeds 10 centimeters, and 10 centimeters is just the width of 4 fingers, you can with 100% confidence, you know that is not a tibial bone stress injury. That's going to be metatarsal or medial tibial stress syndrome.
Yeah.
For me, if I think it's less than that, and I suspect a bone stress injury, I mean, I don't have that person continue running.
Yeah.
I think that's a non-starter for me. I think that they need to take some time off, and they can do some cross training, and we can do some management there. But and we really want to catch it early, because if they continue running on it, the likelihood that this is going to progress into a more severe bone stress injury, which is going to require a longer recovery period. There's no reason why that wouldn't happen.
Would you say the same about MTSS, that could potentially progress to bone stress injuries, or not?
Oh yeah, that's a great question, and I think there's a lot of debate. It seems like it's kind of dying down a little bit, but for a while there, a lot were kind of pushing this idea that MTSS kind of fell under the bone stress injury, was like a precursor to an actual bone stress injury. I would say that most would say that that's probably not the case. They seem to be different clinical entities. That's not saying that people who develop medial tibial stress syndrome don't also have some impaired bone architecture. And so there are some studies that have shown that medial tibial stress syndrome is the prior MTSS does seem to be a risk factor for developing a tibial bone stress injury. But I would say that it's the fact that it's on this continuum. I don't know if I see that. I mean, I see a lot of, you look at most high school runners are going to develop MTSS. And for those athletes, I work on trying to, try to control their biomechanical loads. For me, I tend to put them into like a high drop shoe, reduce their volume, in particular, some of their volume of like speed work. And usually, I don't know, when I look at that population, I think of again, this is a high school athlete, holding them out of athletic participation. I think the risks are much greater there than continuing to run with MTSS. I don't know. How do you all approach that?
Yeah, pretty similar. Like I'll cut you off, Kelly, because I just wanted to get this question in, because it was one I've been dying to ask. When you have, diagnosed someone with MTSS and you've reduced their training load, and then you're getting them stuck into the rehab to build that bone resiliency, how acceptable is pain during the rehab? And I'm thinking similar to tendons, where, there's some studies to say less than a 3 out of 10 is acceptable. How does that with bones? When you're doing plyometrics and heavy calf raises, is a little bit of pain acceptable and considered normal?
Yeah, for MTSS, yeah, that's exactly what we do. I think of it, I use that pain monitoring model for MTSS, which by the way, and I don't know if everybody's aware of this, but that pain monitoring model that you're referring to, that Karin Silbernagel published back in 2007, it actually got started in patellofemoral pain in 1997. So one of her PhD supervisors, Roland Tomei, used it for rehabbing patellofemoral pain. So it's been around for other diagnoses. So that being said, I feel like you can feel comfortable using it for other diagnoses for sure.
And then as well, like if you have diagnosed more severe, MTSS or stress fracture or tibial injury, what's your general protocol of offloading? I know here in Oz, it's a little bit of a difference, but it's generally 6 to 8 weeks in a boot. And if it's more severe, it's complete non-weight bearing, or then if it's less severe, more just weight bearing in a cam walker or a moon boot.
Yeah. So yeah, there are definitely some different approaches to this. And I think in the United States, there's the Frederickson grading system here. And when you look at the higher grade of the Fredericksons, those you're looking at, 6 weeks of non-weight bearing or controlled weight bearing. I think for the lower grades, so like a grade 1, which is just basically just some early bone marrow edema, I think what most people would consider to be like a stress reaction. Those folks they only need a couple of weeks of controlled loading, and they might be able to get away with, if they can walk without pain. And I think that's totally fine. I think that's kind of what you want. But I think for the most part, if we're taking kind of your average person with a post-remedial tibial bone stress injury, I think let's kind of talk about the middle of the bell-shaped curve. I think you're looking at 4 to 6 weeks of controlled weight bearing. I think you're looking at I think using bilateral crutches makes a lot of sense for the first 3 to 4 weeks. Then I think then you can start weaning them off of those. I like using crutches a lot because the gait doesn't seem to get altered a ton, and I like, then you can really use the crutches to kind of control that person's the amount of weight that they're bearing through that limb. And the goal here is they really should not be experiencing any pain when they're loading it. So if they're experiencing pain with walking, then that's telling you that you need to offload them a little bit more. And you should do periodic reassessments on that so that you're continuing to progress the amount of weight bearing they're having. You shouldn't just say, okay, so 6 weeks, no weight bearing whatsoever. The idea in those 6 weeks is that you slowly start seeing if you can increase the loading. And if that patient experiences pain when they're walking with their crutches, then that's a good sign. You need to get them to unweight that limb a little bit more. And that pain can occur during the actual loading when they're actually stepping, or later on in the day. And this usually is what happens. We get some increase in bone marrow edema, and that's like pain at rest, so pain at night or pain upon waking the next day. Those are really good signs that the athlete needs to pay very close attention to, that they need to reduce the amount of loading that they're doing. It's just that bone is just not ready for that yet. So I think equally okay is to use a cam walker, as you mentioned. And a cam walker, it has that big cam. And what that cam does, it's like a rocker soled shoe. It reduces the moment arm on your plantar flexor. So it reduces those plantar flexor forces considerably, and also the rigid sole does as well. And so, as long as it's a higher boot, I think those are okay. I would say that we end up, most athletes we end up seeing use crutches, I would say. And for me, I think that makes more sense, because if you're walking in a boot, it's really going to change your overall gait dynamics. It's going to change the way you're loading that bone. And I think that might introduce some other issues down the road.
Yeah. Kelly, did you have any questions regarding offloading? That was awesome. I'm pumped up at the moment. This is such good knowledge. I'm excited.
We got a little bit, I guess, kind of back on topic again from the rehab journey that we were sort of going down with the tibial bone stress injury. So I guess once someone has started walking again and is maybe walking and going for brisk walks for a couple of weeks or 1 week, then how are you sort of planning their return to running program?
Yeah, I would say even like a little bit before that, what I would start saying is that around week 4, I start, even if they're still on crutches, and we start introducing some bilateral heel raises. So start getting them ready. So just, full weight bearing, bilateral. So of course they've only got 50% of their weight through that limb. We have them do some calf raises. So we start doing those. Then around week 5, we try to start introducing.
Should they be pain-free? Those raises?
Yes, they need to. Yeah, they should be
pain-free.
Yeah, if they're experiencing pain with that, that's too much load. Pain. I really wish we had a better tool, but that's the best tool we have right now for determining like if this athlete is tolerating the load. It seems to work well. That's what brought them into your office to begin with. So. It seems to be okay. And of course, if the athlete does experience any pain, it's okay. For me, I just say, okay, we're going to take 3 weeks or 3 weeks. We're going to take 3 days of reducing the overall load. And that seems to be enough for them to calm down. And then they really should be just fine after that.
Sorry, and you were saying, so within that 6 weeks, start to come out and do some heel raises, and then they're progressing. Say they got to the 6-week mark and them come out of the boot or the crutches. What's it looking like for their return to running?
Yeah, so we like to have them they need to be walking outside the boot for 3 straight days without any exacerbation of should be pain free. And then at that point we have them do 10 single leg hops. And if they can do 10 single leg hops and they don't have pain during the hopping and they don't have pain the next day, then that's the time that we start doing a return to run program. We typically start off with having the athlete walk more. We start getting their overall walking up to 30 minutes straight at a time. And ideally we'd like to get them up to 40 minutes. The reason why we want to do that is because if we just have this person who's been walking on crutches and we suddenly throw them back into a return to run program, and let's say the average person is just getting, I don't know, let's say 6,000, 7,000 steps in a day, and they do a 30-minute walk run program. I mean, they're going to almost essentially double the number of loading cycles that they're experiencing in a day. And so we really like to get them doing just a period of walking. It might just be just for a week before we start doing that. And it seems to make things go quite a bit easier. So we really try to start doing that. And when they can fully weight bear, we start progressively increasing the amount of walking time that they're doing, with the idea being that we can recommence running around week 6. Yeah. And again, going back to the different grades, that might be plus or minus. Some people might be a lot quicker than that, and some are going to be a little bit longer out for the more severe bone stress injuries. And there seems to be a continuum when we're looking at the tibia as well, the posterior medial tibia. It's not like this dichotomous thing. It's you have a bone stress injury or you don't. There really does seem to be this overall continuum that's occurring.
And does that look like walk running as well? Like say 30 seconds of walking, 30 seconds of running, 4.5 minutes of walking for 4 sets or something like that.
Yeah, exactly. I mean, yeah, you'll see there are a lot of different programs that are out there. That's what we basically, I usually have them, warm up for walking for 5 minutes. Then we start them doing like a minute on, 3 minutes, a minute of running, maybe even less than that, 30 seconds of running. But typically a minute seems to be fine. And then have them do 3 minutes of walking. And then we'll repeat that 5 reps or 6 reps. And then we finish with some walking, at the very end. For me, I tend to take the first 2 weeks they're pretty boring. I don't increase each session. And the reason is that you're throwing a lot of new loads at the bone, and the bone hasn't experienced those loads in 6 to 8 weeks. And so for the first 2 weeks, we try to go a little bit slow. It's not till week 3 where we start really increasing the amount of volume that the person is doing. And doing that by week 6, that has us up to running 30 to 40 minutes continuously. And at that point, they typically are well on their way to getting back. What I just described is the fastest I think you can do it. That's a pretty fast schedule. You're talking 12 weeks of back before they start kind of getting back to somewhat of early stage, like early training loads. So I really think that that's the fastest you can go. I think that when we look at what the athlete can do and what we can do, it's really hard to speed that process up. And what's really driving that is the initial grade of the injury. So if you're, it's one of the questions that we get a lot is like, hey, is there anything I can do to speed up the healing of this? And there doesn't really seem to be any like real proven way to do it, but there are lots of ways you can slow it down. And that's what you really want to prevent that athlete from doing. And of course, the big one being is too much weight bearing in the first 4 to 6 weeks. That's the biggest thing that's going to slow them down. The other thing too is that, and there's been some really great activity monitoring or actigraph studies where they've put wearable devices on athletes when they're recovering from a bone stress injury. And a lot of these athletes, they're not changing their overall activity level. So they're just taking the amount of volume that they were doing with running and they're replacing it with cross training. And that cross training often can be very vigorous. And so it's important to keep the reins tight on your athlete, particularly for the athlete who you suspect is dealing with some red S issues, that red S is still going on, because the athlete will figure out a way often to continue to have a very high train limit. So for me, I like runners to get a little bit out of shape when they're recovering from this, because it's not only is it time for your bone to heal, but it's also a really important time for you to get your physiology back in order if there's an underlying physiological contributor to this bone stress injury.
Yeah, I often say that as well. I'll often say, it's not a bad thing to lose a bit of fitness, because when you do return to run, eventually it's going to be slow and it's going to be a lot less than what you're used to. So, if you're super fit, then you'll just get frustrated. So I definitely say that too. I have another question on speaking about time frames, which is something that I tend to struggle with a little bit myself with patients, is setting realistic goals in regards to returning to races or competition. It's often tricky because I'm trying to sort of give them a really realistic time frame, and it's frustrating for them because it's not as soon as they want to. Well, how do you best approach that?
Yeah, I mean, I think if they're in any sort of build up for a big event, I think they need to reassess their goals. I think they need to probably find another event that's going to allow them to do that. I think, we're in the United States, college and high school, it's really built around like the fall cross country season and then the spring track season. I think if you get a bone stress injury at the beginning of one of those seasons, your season's done. I think you need to just, which is really unfortunate. But yeah, I think you really need to reassess and start targeting, some spring races if you got your bone stress injury in the fall. If you're leading up to a marathon, I think it's the exact same thing. I think that, you probably need to go back to the drawing board and figure out what's going to happen, because as I mentioned earlier, you have a 600% increased risk of having a subsequent one. And so you need to be really smart and very deliberate. Don't think it's a, this like rogue event. There usually is perhaps something else going on there that you need to consider. So yeah, I think it's a really hard thing. I mean, there's runners tend to have a perfectionist attitude or view of things, and I think that Lace Lewetke, who's in the United States, she's in Wisconsin. She's done a lot of work looking at perfectionism in athletes as it relates to bone stress injuries and also medial tibial stress syndrome. And there seems to be a very positive relationship between the two, meaning that more perfectionist tendencies that the athlete tends to demonstrate, the greater their risk of developing some sort of bone stress injury that's going to occur there. And then because of that, those athletes, when they're coming out of this injury, they're also the same ones that tend to be very objectively driven when it comes to looking at running volume or running time in their training. And so they often will start ignoring some other like internal, I guess, like how running is feeling and how fit they are, and being realistic with themselves. And they'll often, this is, one of the highest risk time periods for developing a bone stress injury is in the 6 months or 6 months to a year after you've had one. And the big reason for that is because not only do we, not only are we recovering from bone stress injury in that specific site, but there's been some really great research that has shown that we lose bone density throughout our body because we've reduced the loading there. We're just not training with the same types of loads. And so you've lost bone strength elsewhere. And so that's another big reason why we tend to be at high risk for developing some sort of bone stress injury that's going to occur. The ones I worry about the most are the ones that do a lot of non-weight bearing cross training in the early stages. So swimming, stationary biking, those sounds, and I think a lot of people do those, and I think a lot of clinicians prescribe those. But something to think about is that when astronauts are training to go into space, they do a lot of their training in a swimming pool. And the reason why they do that is because it's a weightless environment. And we all know that when someone is returning from space, that they've lost a lot of bone health. And so that's a very poor modality for these individuals, because you're basically putting someone probably who's got some compromised bone properties in a position where it's just going to accelerate that.
Yeah. We mentioned earlier on when we were talking athletes who train year round, and I know that Stuart Warden often recommends a skeletal reset week after every sort of 12 weeks or so. Can we talk to that as well, Rich?
Yeah, I think that when you look at and Stu's done a lot of really awesome research in this area. Mitch Rao has also done a lot of work in this area as well. He's looked at sports specialization. So we know that sports specialization is a major risk factor for bone stress injuries in adolescents and also early 20-year-olds. And the big reason for that. So let's take it back a step back. When I say the highly specialized runner, I'm talking about the high school runner who's running 9 months a year or more. They're not doing other sports. Those athletes, because of that, they tend to be a little higher risk for RED-S. But one of the other big reasons too is that not only do our bones become a little bit less responsive to loading repetitions within a cycle, within an actual training bout, it also will occur over time too. So across the season. So as the season progresses, you're going to still be accumulating bone microdamage, but the bone is going to get a little bit less good at responding and laying down new bone. And so once you get to the end of 12, 16 weeks, you're still accumulating some bone microdamage, but the bone is not laying down new bone mass. So there is this idea of we should do, a week or 2 weeks or maybe even 3 weeks of deloading and then start loading again. There's probably a better way. So that would be one way to do it. The other way to do it is that every third week, we should have a period of time when we're reducing our overall running volume. And we're also reducing the overall magnitude of the loading. So we should probably lay off of our speed work every third or fourth week. That's going to provide kind of a mini reset. And that's going to allow us to kind of stretch out those 12 weeks out to 16 weeks and perhaps a little bit longer. But yeah, we should definitely have a period of deloading, and that's going to kind of resensitize the bone. And so when I'm working with high school athletes, a good thing to do is fall cross country season, take a little bit of a break, go into basketball, or just ski in the winter here would be a great thing to do, where you are doing some deloading, and maybe in the spring do mountain biking or something like that. That would be a great way to do it. And then you're still getting, the mountain biking is going to provide a lot of the impact type forces are going to be helpful for building bone health. And at the same time, maybe do some running at the same time. But having that winter period where you're doing maybe even a couple months of deloading is going to be really healthy for the athlete's skeleton. That doesn't seem to be the case as strong once we reach skeletal maturity. I think you don't have to, because when you're an adolescent, you're asking a lot of the adolescent skeleton. You're asking them to basically accommodate to the training loads that are being thrown at them, but also get stronger. The bone's supposed to be getting stronger at this time period. Once we've reached our mid-20s, it's probably not as important, but you still need to be really careful in the middle of the season not to suddenly say, I don't know, you're on Instagram or something like that, and you suddenly see that doing plyometrics will really help your running performance. And halfway through the season, you start throwing this big plyometric program at your bones. Your muscles are going to respond to that, but the bones are not. And in fact, that's a really great way to get a bone stress injury in the middle of the season, is to suddenly throw some new, unique, high magnitude load at a time when the bone is not going to respond to it. So you need to be really careful about that as well.
What's your opinion on bone stimulators and shockwave? And I know there's one paper I'm thinking of that has shown a really low frequency shockwave can have a little bit of an effect as it's similar to a bone stimulator. What do you think of those two treatments, as in isolation shockwave and a bone stimulator?
Yeah, I don't know a lot about shockwave therapy. I know that Adam Tenaforte, who's a sports medicine physician at Harvard, he's a big advocate of using them, particularly for MTSS. I think he's got some good clinical success from an anecdotal standpoint using them. I don't think anybody's done any sort of trials with them. I know that the other one would be low intensity pulsed ultrasound. And so you'll see, it's also, the acronym is LIPUS. You'll see the use of LIPUS has been done. It seems like there's some promise in some lower level evidence papers, but it doesn't seem to really hold up with higher evidence papers. So LIPUS seems to make the most sense for someone who has had a delayed union, bone stress injury. I think those people are going to be the folks that are going to make the most sense for that. We don't do that. We don't use either of those modalities, but there does seem to be some promise there. But it's funny, the LIPUS literature has been around for a long time. People have been talking about this since the early 2000s. I know, like I had a delayed union clavicle fracture in 2005, and I used a LIPUS device. My surgeon ended up having surgery on that. I used a LIPUS device then. So it's kind of like, well, I don't know. It's this modality's had 15 plus 20 years to get some evidence behind it, and it still doesn't seem to be there. That makes me think that it doesn't hurt, but it doesn't seem to make this huge difference. I think if you are going to use it, the way to do it would be very much like these very micro sessions of bone loading, where you do them for 10 minutes, you use the LIPUS device for 10 minutes, 3 times a day. So you allow the bone to recover in the 4 hours in between each one of those sessions. And I think that's probably going to be the best way to do it, rather than doing like a 30-minute or a 45-minute session one time a day. I think you're not going to get anything out of once you get past the first 5 or 10 minutes of using that device.
Yeah, I wanted to ask, and I know you got running short for time. I didn't want to take up too much of your time. I did want to ask around when you are returning to running, like post, you come out of the boot or the crutches, and you are doing your walk run intervals. In combination with that, what would you recommend? A couple of questions, like the frequency of running with the week, and then the frequency of strength training within the week as well, and how that would look. And if you were returning and let's say you build up to 3 minutes of running and 2 minutes of walking, and you were to experience some pain in your shin, is it a rest for a week or a couple of days off and start again? Or how do you kind of address that?
Yeah, for me, I just do 3 days. 3 days of deloading seems to be adequate. It allows that mechanical irritation and biochemical irritation to go down, and then then you need to go back 1 to 2 steps in your progression. That's your bone's way of saying, hey, you overcooked it.
Yeah,
you got to back off a little bit and see how it goes. I think as far as frequency goes, 3 to 4 times a week is plenty of running, balanced with some cross training. We do our weight training on the same days as the run sessions and the return to run process, so that the bone can really recover very well on the off days. And that's the same way we manage our tendinopathy patients as well.
Yeah, great. All right, mate. Thank you so much for coming on. Is there, I know people, and I've mentioned it before, people can find you through Montana Running Lab, but is there anywhere else they can find you? Have you got anything coming up or that clinicians can look out for?
Yeah, as I mentioned before we jumped on this, I started recording. I'm going to be in Melbourne. It looks like in April. So we're going to do a running symposium. So I'm looking forward to doing that. I have a couple of online education offerings we're going to start offering pretty soon, and so I'm hoping to roll those out. We'll announce those on our Instagram site. But we'll have a master class on bone health, and also a master class on like lower limb relative overuse injuries as well.
Yeah, that sounds awesome. Sign us up for that. Yeah, we'll just say
I'm very
would be
keen
awesome.
for
Keen to come down. Did you say it's in Melbourne? You'll be coming too? Did you say Melbourne?
Yeah, it's going to be in Melbourne. Yeah, we're going to be at La Trobe University. So that's what I'm really looking forward to doing that.
Yeah, that'll be awesome. And yeah, Montana Running Lab over on the Instagram. But hey, thank you so much, one, for coming on the podcast, but also for the incredible work that you put out. I know that you've helped both Kelly and I a lot clinically, and I can only imagine the other clinicians throughout the world, some of your infographics and research as well, that has helped people and patients.
Oh, that's wonderful. That's great. Well, that means a lot. That's the whole reason why I do it. So thanks for that. I really appreciate it. I'm glad that it's helping some. It certainly is a lot of fun, and I learn a lot doing it as well too. So thanks.
Helping us and all of our patients.
Awesome.
Thank you so much.
See you later, Rich.
All right. Thank you.
Bye.